Yes, you can say.
Good evening, Professor Glenda Gray.
Good evening.
How are you doing, ma'am?
I'm doing fine.
Okay. Okay, we shall start promptly at 18:30 or 6:30 p.m. We have a few more minutes and then we commence the session. Once again, thank you for accepting the invitation and to be our guest presenter this evening. It is indeed appreciated, ma'am.
It's a pleasure. I'll just so you'll just ask me when to share my screen. Is that okay? Is that all right?
Yes. Can I go off now? Submit about a problem here. Okay, fine. It's now 18:30, 6:30 p.m., and we are commencing with our conversation with Professor Glenda Gray. The respected ulama, the guest speaker, Professor Glenda Gray, members of the Board of Governors, ladies, gentlemen, learners, and well-wishers, Assalamu alaikum wa rahmatullahi wa barakatuh. A very good evening to all of you. This evening, indeed, is a watershed moment where we have Professor Glenda Gray to address the stakeholders of Middelburg Muslim School. The terrain for discussion is schooling during the coronavirus pandemic. The introductory remarks of our guest speaker, and they are as follows. Professor Gray was born in the mining town of Boksburg. At the age of 6, she decided she would become a doctor. She commenced her studies at the University of the Witwatersrand in 1980 and specialized in pediatrics. Professor Gray is actively involved in AIDS research, and in 1997 was awarded the Femina Woman of the 90s. Gray was presented with the 2002 Mandela Award for Health and Human Rights by Nelson Mandela. Indeed, she is an anti-apartheid activist. In 2014, Gray became the first woman president of the Medical Research Council of South Africa. In 2017, Gray was named as one of the 100 most influential people by Time magazine. In 2020, Gray was listed amongst Africa's 50 most powerful women by Forbes Africa. Also in 2020, Gray was appointed to the South African Government Medical Advisory Committee owing to the COVID-19 pandemic in South Africa. Ladies and gentlemen, before I hand you Professor Gray, this is the format for this evening's discourse. Professor Gray's presentation is twofold. The first 15 minutes will comprise of her address, followed by a question and answer session of approximately 15 minutes. At the beginning of the presentation, all microphones will be muted. When the question and answer session commences, kindly raise your hand engaging the computer. Your microphone shall be unmuted and you may pose your question to Professor Gray. You may also exercise the option of texting your question to the school's cell phone. The number is as follows: 071 688 596. I reiterate, 071 688 596. The question will then be forwarded to Professor Gray for attention. Bear in mind, all questions must be within the context of schooling during the COVID-19 pandemic. Perchance for those who do not enter this session, you may view this presentation on YouTube. The link is provided on the invitation for this presentation, and this was made available on the parents chat group. Dear audience, it is indeed my pleasure to hand you Professor Glenda Gray. Over to you, Prof.
Thank you so much. I'm just going to share my screen so that I can get the presentation up. I'm going to put that on. Can you all see that? I'm just going to start that. Are you able to see my presentation?
Yes.
Okay, so good. Assalamu alaikum. Good evening. It's wonderful to be able to talk to you tonight. I'm also a parent. I have a 16-year-old son who's also at school, and so I guess I have some experience with parenting during the COVID epidemic and having to navigate the school. So as a pediatrician and as a parent, I'm very happy to talk to you because I know parents are very concerned about schooling in this era. So what I thought I would do is just give you a quick update of the epidemic in South Africa. This is as of yesterday, and you can see the different provinces, the cases, the cumulative cases by province, and obviously Gauteng has borne the burden of the epidemic. We are seeing it slowing down, and we are seeing the death rates coming down in Gauteng. KwaZulu-Natal and the Western Cape follow with the Eastern Cape in the fourth place. There is a surge going on in the Free State, and that is the province that has the most cases at the moment. And but slowly and surely we are seeing the peak past, and we are seeing death rates slowing, and we're into what we would call a steady state as far as the epidemic is concerned. And that is why it's nice to talk about schooling and what we do in this period of time while we haven't completely eradicated coronavirus from our country, and what we think will happen for the next year and a half in South Africa. But just to let you know, and I think a lot of parents are concerned about letting their children go to school, And this just shows you the daily report by gender and by age in South Africa. And it shows you the distribution. And this has been fairly constant from the beginning of the epidemic, where we've seen a very little burden of coronavirus in young children, and then increasing as children get more mobile, and that's from the age of being a teenager, peaking at the 30 to 34-year-olds. These people are probably the most mobile in the country, young adults who are mobile, going to work, and so they will be the people that are mostly affected by COVID-19. Now, the good thing about COVID-19, and that's the discrepancy about the epidemic, is that largely this epidemic will be people who get infected by SARS-CoV-2 will be largely asymptomatic, and the older you get, and the more comorbidities you have, the more likely you will be to have been adversely affected by SARS-CoV-2. So this just shows you how little infections are seen in children of school-going age and young children, and the peak as people become more mobile or moving around in society, and then the distribution towards the older age groups. So I think that's an important thing to see, who would be the drivers of the epidemic or the transmission in the country. If you have a look at hospital admissions and deaths by age, again, you will see that children have been largely spared by hospital admissions and by deaths, both in South Africa and beyond. Obviously, as schools open up and as children mix, particularly 15 to 24-year-olds, we will see an increase amount of young people getting COVID-19, and we're seeing that happen in the US universities, and we're also seeing that a lot of the epidemic happening now in Europe and in Spain is largely fueled by 15 to 24-year-olds who are moving around quite a lot in society. But I think I just wanted to reassure you about school-going children. You can see that there's very low admission rates and very low death rates. For children to die of COVID-19, they have to have severe underlying comorbidities, underlying infections like cancer. And so it's something that we need to continue to observe. But at a global level, we've seen that children are largely spared from the epidemic, which is wonderful news. Obviously, the older you get and the more comorbidities you have, like obesity, diabetes, hypertension, kidney disease, the more vulnerable you are to having adverse effects of SARS-CoV-2. And this is, I guess, where the issue is. A lot of families have intergenerational households, and so a lot of parents are scared to send their children to school because they're worried that the children will infect elderly people or elderly relatives that are in their household. And so we have seen that younger children are less likely to transmit the virus as compared to older children. And obviously, the older the child gets, the more they behave like adults and can transmit to a higher degree. But largely, we want to reassure both the teachers and the parents is that the schools are not going to drive infection. And a lot of the infections that have occurred at school have occurred in the community and have been transmitted. But kids have not been the index case and transmitted largely at a school level. We obviously we need to be careful about practicing physical distancing in households where elderly relatives are living, and we'll discuss that further in my next slide. But I wanted to first start off with showing you how well your school has done. In fact, you should be very proud of your school. I shared this with some of the doctors I work with, and they said, "Wow, what a wonderful school! What a wonderful example of management." And just to show you how well your school has done with the amount of children that you've had in your school, you can see that you've been relatively spared any excessive infections, and that obviously the interventions you've put into place have worked very well. And so I want to first of all congratulate you on such wonderful statistics, and also the fact that statistics are collected at your school, and that you're able to manage any outbreak that you see. Also, I think I want to also congratulate you on the amount of attendance of children at your school. And now you can see that you have an amazing amount of attendance, which is really good. And given the high rates of attendance and the low amount of cases you've seen at your school, I think that you can be rest assured that the school is managing the epidemic very well. And so it's very gratifying to see that. We have spent a lot of time looking at how to keep schools open and how to open schools. And we've looked at both the American Association for Pediatrics, the South African Medical Association, the South African Pediatric Association. We've had two advisories at the Ministerial Advisory Committee on COVID about schools, and we've also worked with the Department of Basic Education to try and reassure parents, teachers, and school management about keeping schools open. We published last Friday in the Daily Maverick a scientist collective on schools. So if you want to go into Daily Maverick, just Google Daily Maverick school opening for COVID, and you'll find our article that we've written together with a whole lot of pediatricians and together with the Department of Basic Education. But we have a 10-point plan for schools, and we think that if you keep to this plan, you should be fine. And the first thing is to set up a COVID-19 school management plan. So it's important for parents and teachers and everybody to know who's in charge of the plan and who to go to for assistance and help. So that's the first thing. Set up a school management plan, and it seems like you already have that because you have such good statistics. Important thing to continue to do is to implement what we call non-pharmaceutical interventions. And these are wearing masks properly, covering your nose, washing your hands regularly. In some schools, there's a bell, and every hour the children sanitize their hands. And also the third part of the non-pharmaceutical interventions is physical distancing. And part of physical distancing is also ventilation and avoiding crowds and congestion. So that's very important. As the rates of COVID come down, we start to see people getting tired and fatigued about wearing masks, washing your hands, and keeping distance. And this is the time that we need to continue to implement the NPI. It's also very important to know the age profile of your staff who teach and who are present at the school, and also what their comorbidities are. So we've asked that the school compiles the age profile, and that the school is aware of all the comorbidities, everyone who's got hypertension, diabetes, and other comorbidities like HIV and TB. It's important to know. And obviously the teachers that are old and the teachers that are sick, they should not be the frontline teachers, but should support those teachers that are in the front line. We also think it's important that you know which children are sick and which children have comorbidities that place them at risk of severe COVID-19 or of getting symptomatic. And if you are worried about any children at the school, it's always important for for the parent, the teacher, to consult a doctor or a nurse to decide on how to manage the child. If there is a child that you are worried about, I think it's important to speak to the parents and to decide how you're going to teach the child, whether the child needs online schooling or whether the child can be in the classroom. And even the classroom, close to a window. Always important to have that child close to the window, have windows open, and maybe a little bit further distance from other kids, and also to keep an eye on the child to make sure that they are maintaining physical distance from other children. It's also important, we've seen at the hospitals that a lot of infections have happened in the tea room. And so nurses and doctors are very good in the wards. They put on their N95 respirators. They're dressed up in their PPE, and then when they come into the tea room, they let their guard down. They get close to their friends, and that's when the transmission happens. So we do say, we do recommend that you limit the use of the tea room for teachers, and you also limit in-person meetings with other adults to a maximum of 5. And if you are having meetings, to keep the windows open, maintain the distance, and to wear masks and sanitizing. We ask that you keep the classrooms and desks cleaned frequently. The Department of Basic Education recommends twice a day. In some schools, the children themselves wipe the desks down frequently and contribute to keeping the desks clean in their areas. We also recommend implementing practices to decrease congestion in classes, and this is to space out your teaching. I know a lot of schools are doing alternate day teaching, and on the day that kids stay at home, their parents help them with the lessons they have to get through. Some schools have implemented two class periods, one in the morning and one in the afternoon, and in a way to decrease congestion. In lower grades, some teachers walk to the classes to try and avoid congestion and keep children contained. And in older grades, this is not possible because kids have different schooling activities. And in this case, it's always just to try and avoid congestion, particularly in corridors. Always important to remind students to implement physical distancing. Sometimes it's very hard because children want to be close to their friends, and just to try and maintain physical distancing by having COVID monitors that just keep an eye on the space. When we first started to open up our clinics in our hospitals and in our research areas, we had what we called a COVID monitor. They would just keep an eye on the staff and remind them, because people forget about distance, and just to keep reminding people to keep physical distancing and to make sure that your masks are worn properly, and to keep cleaning your hands. In some hospitals and in some clinics, there's a bell also that rings every hour, and people stop and wash their hands and sanitize, which is important. We've also recommend using open spaces as much as possible to do teaching. I know this is hard in winter. When it's cold, everybody wants to keep the classrooms closed and warm, but this is the time when we need to keep our windows open and make sure that we use spaces as much as possible. We also don't recommend choir and singing, but we do think that sport is important, especially if it's non-contact sport, and that children who are playing soccer keep their distance, very little contact with each other, and then to make sure that hands are washed and sanitized, and masks are worn during this period of time. It's important to have daily checks with staffs and learners, just to make sure that anyone who feels sick or is symptomatic checks in and tells the staff about the illness, and also a good relationship with the parents and the school. So that's very important. There's a lot of stigma associated with COVID-19. People are embarrassed and to tell anyone that they've got COVID-19, and sometimes may not want to disclose this because they're scared of stigma. So we should just make sure that we try not to stigmatize COVID-19 in any way, so that people don't feel embarrassed that they may have acquired SARS-CoV-2. I think that I'm going to just stop there about the school, but I did want to comment on the importance of treatment and prevention. And at this moment in time, we don't have a prevention method, and we don't have a vaccine for COVID-19. But we are very lucky that in about 2 weeks' time, on the 14th of September, there's going to be a large-scale vaccine trial that's going to be executed throughout the world. We're going to be enrolling 60,000 people, at a global level, and between 10 and 12,000 people in South Africa. And we are going to have 32 sites across the country, and we are going to have a site in Middelburg, at the Merck site in Middelburg. So I wanted to just let everybody to know about this, because I think it's very important. We want to get everybody to enroll. I myself have volunteered to be a vaccine participant in another study. So in the chimp-ad or ChAdOx study, that is a vaccine that is developed by Oxford, and AstraZeneca has acquired the rights to develop it. I was fortunate enough to volunteer for that vaccine trial in UCT, and this study also, it's an adeno 26 viral vector platform. We're very excited about this, and this is a single dose vaccine trial, and we want to encourage as many people to enroll. We'll be enrolling first people over 18 years of age, and then people over 60 years of age. We will also be looking at people with both comorbidities and people who have no comorbidities to enroll into the study. So I want to encourage everybody to visit Dr. Tayyib's site and to find out more about this vaccine trial, because we're very excited about it, and you'll be hearing a lot about it in the next couple of weeks. So I just wanted to let you know about this vaccine trial, which will be taking place in South Africa. I wanted to thank you. I'm going to first of all thank Mohammed Bamji from Witbank. He is the person that put me in touch with the school. I want to thank all the teachers, parents, and children of your school, because I think you're doing a wonderful job, keeping your school open and well controlled in terms of COVID-19. And also I want to thank Yaqub Mansour for inviting me to do this talk today. And I think it's more important now to hear from you and to try and answer some questions that you might have about schooling, and whether I have any good suggestions for you. So I'm going to stop my sharing of my screen, and then I'm going to take some questions from you, if that's fine.
Thank you, Professor Glenda Gray. The audience, you're now open for questions. Kindly unmute your microphone and you can pose the question that you so wish. Prof, I have a question that came through me via the text medium, and it reads, is the requirement for daily temperature checks still important? I'll repeat the question. Is the requirement for daily temperature checks still important? Your response?
So I think that what's more important is the check-in, and I think using the temperature thermometer platform allows for the staff member to check in with the pupil as they arrive at school, and it kind of it reminds you of the fact that we have to implement non-pharmaceutical interventions. So temperature itself may not be a very sensitive or specific indicator for COVID-19, but I think it's a powerful reminder as you get to school. When the teacher takes your temperature, it reminds you of the fact that we're in an epidemic and that we need to take care. So I think it's more the symbol and reminding us why we should be careful and that we're in an abnormal situation in the country. So I like it for that reason, even though it may not be sensitive or specific. I think it's a good reminder about where we are in South Africa.
Hi, Glenda.
Hi.
Dr. Basa speaking. I'd just like to know about asymptomatic carriers and the risk that they pose for people at home.
So that's
do you think that because they're asymptomatic, we are missing them or we're missing to test the youngsters at school?
So I think that the important thing about asymptomatic or mildly symptomatic carriers is the importance of making sure that we implement non-pharmaceutical interventions. And so if you don't know whether someone is symptomatic or not, it's always important to make sure that even in your household, that physical distance is kept and that children are washing their hands. And if there is an elderly person in the house, I always recommend around the elderly person that you wear a mask, you keep your distance and make sure there's good ventilation. And so I think the most important thing is to try and minimize physical contact and make sure that there's good ventilation, particularly if your school child comes home and there are elderly parents there. Try and maintain the distance. The further you are away from someone, the less likely you are to acquire any of the viral particles. And the more viral particles you inhale, the sicker you can get. And so the whole object is to try and minimize the inhalation or exposure to viral particles, and to make sure that there's enough ventilation and enough and to minimize contact. So always encourage your children when they come home to wash their hands thoroughly, and to make sure that if you have elderly relatives, is to try and make sure that you keep a fair amount of distance from the young child or the adolescent. I know it's hard because grandparents want to cuddle their children and they're used to being in touch, but I think for this period of time, it's important to maintain physical distance as much as possible.
The other question I have is about teachers going to school. So should we, in terms of fitness for work, should we say over the age of 60 or comorbidities that are not controlled, for example, uncontrolled hypertension, uncontrolled diabetes, teachers having HIV with CD4 counts less than 200, those definitely cannot go to school. This is just for the benefit of the parents as well and the teachers. I just want to know.
So uncontrolled diabetes is a huge risk factor for an adverse outcome, and obesity as well, and kidney disease. I would suggest that if you do have elderly teachers with severe comorbidities that are poorly controlled, is that they're not in the front line and are not exposed to masses of children. Those teachers I would keep in the background and use them to support teaching, or to get them to teach from home, or in if they do have to come to school, is that they minimize their contact with adults, less than 5 people, always maintaining distances. Sometimes it's important for people to interact and in terms of mental health and depression. And so for a teacher with comorbidities who's protected in the school environment, coming to school may be of huge benefit. But obviously you have to make sure that that teacher, everybody knows that teacher has comorbidities, and that you minimize adult contact to less than 5, and keep 1.5 to 2 meter distance, and always interact with that person in a well ventilated room. And so if it's important for that teacher to come to school, then I would implement those kind of interventions. If it's possible for the teacher to stay at home and teach from home, then that would be a good alternative to coming to school. And you have to balance, I guess. Some people are over 60. Some I've seen very healthy 70-year-olds who play tennis and exercise. And obviously, those people will be less at risk for acquiring adverse outcomes from COVID. But you still want to make sure that they're well aware of their vulnerability and take interventions to protect themselves. Understand, if you have got elderly people in your household, is to try and limit the contact that your family has with other families, in a way to try and protect the the environment where the elderly relative is. And so to minimize mixing of people and minimize interacting with people in your home, particularly if it's in winter where you want to keep the house warm.
Professor, I have another question.
Sorry. Okay. Sorry, just for the benefit of the parents and teachers, one more question. What if a child or a teacher tests positive and everyone around the child is using PPE and there was no contact with the COVID positive patient for more than 15 minutes without PPE?
So that's a good question. So say if someone, say a teacher or a child tests positive, what we recommend is to take the child out of the class and to while the child is waiting for their parent, is to put the child either in an open space if there is no closed room, or if there is a closed room to let the child wait there for their parents. Then I would also we recommend that you find out how long the child was with other people in close contact, and close contact is more than 15 minutes in very close contact without PPE. And if that happens, then we would recommend that that child goes into quarantine for that period. But in the case, as you've just indicated, where there's good physical distancing, there hasn't been close contact for more than 15 minutes, and there's been the use of masks and non-pharmaceutical interventions, then just removing or isolating the child or the teacher from the class would suffice. In the beginning of the epidemic, we would close down classrooms, we would close down schools, and now we don't recommend that that happens. We just recommend that the person is taken out of the classroom, goes into isolation, close contacts go into quarantine, and the area around where the child was is disinfected to prevent further transmission and to make sure the windows are open. So I think that we think is the best way. We also believe that as you get used to, as you get exposed to a case at the school and you learn how to manage it, you get less and less scared and less hysterical about closing schools down, and you manage it and you get confidence in managing it, just like you've mentioned now, is that you don't have to close down a classroom or a school in the case of a child or a teacher testing positive.
I'm glad you brought up the subject of stigmatization, because that's very important, because I've had patients telling me that when they go back to work, everybody just doesn't want to come into contact with them even after 2 or 3 weeks. And I say that's a management problem. The management needs to have a meeting with the staff and tell them about it, because what's going to happen if we have a stigma associated with the disease? A staff member may come to work despite testing positive and will spread it to all the other staff. So I'm glad you brought that subject up.
Yeah, that's very important. I have heard people say, I'm scared. If I've got COVID, I'm just going to wear a mask and I'm not going to tell anyone. And that is the worst thing to do. And in fact, it's once people come back and once they've had the infection, they're probably the safest people to be around, because they're not going to transmit the virus to you. And it's nice for everyone around people to know, okay, you've had COVID, you're not going to give it to me, and your infection is over, and there's no ways you can give me COVID at all. So I do think, in fact, we should be more reassured and feel safer around people that already had the infection, because they're not going to transmit it once they're well.
Professor, I have another question here. Our learners are eager to play sport. What would you personally regard as safe measures to reintroduce sports at school? The emphasis here is on soccer, Prof.
So I think it's very important for children to play sport, and we recommend. My son's school has just asked me whether the kids can play soccer, and so what we've recommended that the children do wear their masks, that they wash their hands and sanitize before they start, that they should not have any contact. And that's the nice thing about soccer, is because it's not rugby. You kick a ball and you move away and you're running around. And I think that's important. So as long as there's no contact made, we don't recommend contact sport. But soccer is a good game, and I would recommend it. And then afterwards, that the ball is cleaned, and that the kids also wash their hands afterwards. And so I know that some parents at my school, some of the parents were alarmed about their children playing soccer, but we've reassured them and to clean the surface, the ball, and to make sure that the kids are washing their hands and are wearing masks. Sometimes it can be difficult to play sport and wear a mask, and I think it may be important just to make sure that children keep their noses covered and to try and make sure that they are still breathing properly. Sometimes kids have problems breathing with masks, and I think it's important just to make sure and check in that the kids are able to breathe properly even if they are wearing a mask.
Prof, there's another question that came in terms of COVID-19. What are the chances of reinfection of COVID-19?
Okay, that's a very good question. And there's been 2 cases from overseas, from Hong Kong, where there's been a report about reinfection. And there's been 1 case that has not been properly confirmed in South Africa. But it all depends on the level of exposure. So if you've had a mild infection and your immune response was not was muted, it seems that people may be able to get a reinfection. And these 2 infections occurred 6 months after the initial infection, and it has to do with I guess exposure, the amount, the strength or robustness of your immune response, and whether and also how your initial infection was the duration of your initial infection. However, we also do know that there are robust immune responses, and we do know that there's long-term memory T cells and other immune responses that do confer long-lasting immunity. So I think as we understand this virus a little bit more, we'll get to know and be able to see which are the people that are more susceptible to getting reinfection as compared to people who have long-lasting immunity. And hopefully more people will have long-lasting immunity and less people will get reinfected.
Professor, another question
Hi,
for you.
Prof.
Oh, sorry.
Sorry.
You may proceed. Thank you.
Yeah, thank you for a great presentation. I was just hoping that you could touch on 2 points for the benefit of the audience. One is the role of antibody testing currently being marketed by the labs. It's my understanding that it's not for diagnostic purposes. So how would that benefit people if they want to go for that, firstly? And secondly, on the epidemiological data that was coming out of some of the studies indicating that children are carriers but not transmitters. if you could comment on that, because I think that will impact on whether parents want to send their kids to school, and the concern about kids coming back from school with the COVID virus and then infecting elderly people at home. Thanks.
Yeah, so thank you. So there are antibody tests that have been registered with SAPRA. The South African, the National Institute of Communicable Diseases and the NHLS evaluated hundreds of antibody tests, and eventually 3 or 4 have been registered with SAPRA. And these antibody tests are useful for surveillance, and they're useful for to try and understand how many people in the community have been exposed and been infected with COVID. But these antibodies aren't long lasting. And so it all depends on when in the time, how soon after infection you do the survey. So usually the antibodies start coming up, and by about 14 to 20 days, you may have a very good response. And this may last for 4 months or so, and then it may wane. And so sometimes if you do the antibody test outside that period, you may not detect it. And also if you do too early, you may not get it. So it's not good for diagnosis, as you say. It's good for surveillance. We're looking at we're investigating the value of whether we should be doing surveillance at schools or at universities. Currently, in our vaccine studies, we see a seroprevalence of 25%, as high as 25% in some areas of the country, and as low as 7% in other areas. So sometimes people come to volunteer for the vaccine trial, and they don't even know that they have been exposed or are they infected, and we might pick up that they have antibodies, and they might not even have known it. So there is some value, and I think that we should always know that there are limitations to the antibody test, and they're not always helpful, but they give us a good indication about how many people in a community may have been exposed already to COVID-19. So they are a useful tool, but not important for diagnosis or treatment. And then so that's important. In terms of children, so the younger children, particularly children under 9 or 10, although they may get COVID-19 infection, they're unlikely to be major vectors of transmission, for want of a better word. So because of their surface area, because the fact that they may have less ACE2 receptors and have less viral load than adults, they're less likely to transmit or be the index to be the cause of transmission. And normally they are the ones who've acquired it from an adult and are less likely to transmit it to adults. The older the children get, and so obviously as they get bigger and taller and have bigger surface areas, they start to behave like adults and may be more likely to transmit as compared to their 10-year-old sibling, but never as much as a big adult male who's walking around without a mask on. And so I think that it's very important that we know that children are not going to be the drivers of transmission, and all the children that have got infected, they usually have got infected at home or in the community, and have not been infected by other kids in the classroom, and that's important. So I think it's important just to note that it's unlikely that your kids will get COVID from other kids. They're more likely to get it from adults, and more likely to get it from adults in the home or adults in the community.
Professor, what is the projected trajectory of the coronavirus, and what your advice would be?
So I think that unless we have a vaccine, we're not going to eliminate or eradicate this virus from our country or any other country in the world. We've seen that after a surge, the country goes into an endemic state, and even countries like New Zealand and Australia are struggling to contain transmission. So just when you think New Zealand is infection-free, you read that they've identified 8 more cases of it in New Zealand. And in Australia, we also see that despite huge efforts to track and trace, community transmission continues, even though it's at a low rate. And so we have to realize that in South Africa, we don't have the kind of tools and resources that you have in Australia and New Zealand, and that community transmission is going to occur and it's going to simmer along. We will probably see increased transmission in periods in our country, I guess, when tourism happens again and when people start to move across provinces, and as we open up our economy, we will see an increased rate of transmission. And our job as citizens is to continue to contribute to slowing down the transmission. And so hopefully we'll never ever get to the peaks that we saw a few weeks ago. But that depends upon us. It's our job to keep the virus transmission under control. It's our job to wear our masks, wash our hands, and keep physical distancing. And to realize that without a vaccine, this virus will be with us for another 1.5 years, or maybe longer.
To the audience, if you have any question, please, you can pose them to Prof.
So there's a question about children under 12 wearing masks. And the recommendation is that kids from 6 onwards should wear masks. And I guess children under 4 definitely it's very difficult for them to wear masks, and there's no value. And the issue around, I think, from 6 onwards, particularly there's a debate about whether face shields are better than masks for young children, particularly because children, the mask hides your face, it hides your ability to speak. And some schools implement the face shields, but to make sure that it definitely covers below the chin. I have seen face shields that are above the mouth, and that won't be very good for transmission. But shields may be better to use than masks in classrooms if they're well fitted. I've seen some schools, I've seen 6-year-olds with masks and shields as well, I must say, in some schools. But I do think that there is a value for a well-fitted shield that goes below your chin.
To the audience, I think we have run past our time. I'll take the last question for Professor Gray. The audience, please, you can come with the last question and we'll close after that.
Prof. Great, Dr. Dave, again, if I may ask the last question, your advice or recommendation in terms of people participating in the vaccine study that you mentioned, and would they, just for the benefit of everyone, be getting a COVID test done if they do decide to participate in the vaccine study? Thank you.
So I think it's a very good idea for South Africans to volunteer for the vaccine trials. I myself did it. It was an interesting experience. You do have, depending on which trial you have. So for the CHIMP-AD, the CHADOC study, before I could get the vaccine, I had to have the nasopharyngeal swab, which is not a nice experience. And then they first tested that, and then when I didn't have COVID, they gave me the vaccination. For the AD26 study that will be at your site, we are looking at the vaccine in all people, so that we don't have to discriminate between whether people have got COVID-19 or not. And so even though you might have a swab, even though you will have a swab, it won't restrict your ability to enroll in the study. And then we will be able to evaluate the impact of this vaccine on people who've been previously infected with COVID-19, people who are currently infected, and people who haven't been infected, to see how the immune response is in all those scenarios. However, if we find ourselves in a situation in South Africa that there's more than 25% of people that we enroll that have got COVID-19, we might first screen people and then enroll them if they are COVID negative. But at this moment in time, anybody who screens is eligible, and although we will do the tests, it won't be a criteria not to be enrolled at this moment in time.
Okay. Before the curtains finally fall, on behalf of all stakeholders at Middelburg Muslim School, thank you, Professor Glenda Gray, for your address this evening. Indeed, it provided a roadmap for education during the COVID-19 pandemic. It did eliminate the phobias possessed by teachers, parents, and our dear learners. You provided hope and confidence during these trying times. Your contribution this evening is indeed a mammoth one, a value-laden one. We salute you, Professor Gray. To the audience, your participation is indeed invaluable. It is only through such a positive outlook on education during this pandemic that will propel Middelburg Muslim School to further heights. Your contributions are indeed noted. With these words, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening and have a pleasant evening forward. Jazakallah. Thank you.
Thank you.